regard to evidence, something that's become popular amongst patients to talk about is opioid use disorder and then using cannabis. What are your thoughts?
The interesting thing with the use of cannabis in the setting of opiate withdrawal, which is where you're often going to be seeing people with opiate use disorder speak to its effectiveness. Its use in opiate withdrawal has been studied to an extent. There are studies that speak to some promise, but don't actually have established evidence on its use for opiate withdrawal. With that said, there are, I think, increasingly more voices lending themselves to the discussion around using cannabis, and in some cases using synthetic THC analogs like nabilone for the sake of easing opiate withdrawal symptoms in a 2 to 4 week period where you can sort of abruptly discontinue.
Right.
Again, that's easier to look at when we talk about nabilone because that's measured, it's pharmaceutical. Much harder to sort of measure when we're talking about medical marijuana dispensed out of marijuana clinics. That is not the same thing, though, as treating opiate use disorder,
right,
which is an entirely different process.
To pivot for a moment, so we've talked about outpatient management, relevant also to docs who are doing shifts in our ED, inpatient wards, people who have been admitted and been in hospital for a few days, whether it's in the forensics department or in general division where I work. What might a patient present with?
A patient could present with increased paranoia, psychosis. It could be an episode that led to them actually being admitted for that very reason, or in some cases it could be a late presentation by virtue of them being an inpatient. Something I actually see far more often because I wouldn't be as, especially in a forensic setting, as experienced, but it's got some interesting parallels as long-term care.
Sure.
Where you're seeing older adults who are transitioning, people who are really not all that old, but for cognitive reasons are actually going into long-term care. And they're often presenting the same way, but increased irritability, increased anxiety, more of a flight risk, which again, I think is different depending on the care circumstances under which they're being seen. But those are situations where there's perhaps an opportunity to have a conversation about cannabis if that's showing up in their drug screen, if that's in any way part of their, admission profile, or if they're actually, sort of openly speaking about it as a reason for why they're feeling the way that they are.
And for docs who are listening, what do you recommend in terms of resources outside of CAMH?
There are a few different projects that I'm involved in that we're hoping can provide some sort of clinical support to clinicians. One that we're looking to make available with legalization. In fact, the ask from the ministry, it's that it's available before the 19th, is the clinical working tool for non-medical cannabis. And we've aptly named it non-medical cannabis for a few different reasons. The first is we're trying to make sure that people are aware that this is not advice on medical cannabis. And the second is we didn't want to make it the cannabis use disorder tool because, I think case in point with our conversation, the legalization of cannabis is not just a cannabis use disorder discussion. In fact, it's mostly a cannabis use discussion. Mm-hmm. And so we're trying to speak to non-medical cannabis, but not just recreational cannabis use. So that's coming out of the Center for Effective Practice, which is CEP.ca. And then I'm also working with a group who are putting out guidelines for older adults. And the older adults present a very interesting intersection because a lot of their asks around recreational cannabis are really how it can help them therapeutically, as opposed to trying something purely for the sake of enjoying cannabis on its own. And so we are putting out a guideline, hopefully before Christmas, that will be coming out on the Canadian Coalition for Seniors Mental Health website, ccsmh.ca.
You've made mention of hyperemesis. Tell us what that means.
Yeah, so cannabis hyperemesis syndrome is a presentation where a person is, understandably going to be presenting with nausea, vomiting, but also a number of other sympathomimetic features like diaphoresis, but also things like abdominal discomfort. In some cases, diarrhea, but that's not required for the diagnosis of the syndrome. In a setting where there's usually prolonged and usually problematic cannabis use. It's hard to quantify problematic use. when it comes to cannabis, so we don't apply the same parameters as we do with, say, opiates or alcohol. But when it comes to frequency and obviously its impact on a person's activity, behavior, connection, that all constitutes problematic. In most of those situations, a person is presenting that way, and again, cannabis is in the background. And so their own insight into why they're coming to you and what they think is causing the problem usually doesn't account for cannabis.
A careful history is critically thus important. What do you do in terms of treatment?
So usually, haloperidol is kind of the mainstay. But
and what sort of a dose range are we looking at?
That's a good question. It really depends. I would say whatever's kind of used in your ED is kind of the norm. Try not to be too prescriptive with doses.
Sure. And ginger?
Ginger's fine. And in fact, any of what we had talked about with regard to acute intoxication with cannabis is probably appropriate when it comes to symptomatic management.
So how does one prescribe ginger?
You actually can just, through the formulary, you can say a ginger tablet. And it's available. I think I'm not even sure what the dose range is for it.
Sure.
If a person is worried about nausea and vomiting kind of going forward, I usually just tell them, if you go to the pharmacy and you seek some counsel from the pharmacist in terms of over-the-counter ginger tablets, they'll probably recommend Life Brand, and they'll be able to tell you 1 to 2 ginger tablets every 4 to 6 hours.
Ginger stat.
Ginger stat. Ginger continuous, or PRN.
Okay, fair enough. You've made mention a couple of times of older adults, and we recognize that presentation and treatment might be a little bit different in this population, because often management's a little bit different in this population. Let's turn it over to you.
So older adults are an emerging issue as from a population standpoint, presentation standpoint. We sometimes, don't expect that to be an issue in that population. But more importantly, we sometimes think that the considerations for different substances in older adults apply the same as they do with mainstream. Cannabis hyperemesis, cannabis withdrawal, in both of these situations you're seeing a change in the vitals, you're seeing a change when it comes to nausea, vomiting, so some hypovolemia issues. You're also concerned, again, with how destabilizing that can be as far as hypotension. Those can actually be morbid in older adults. And so medical clearance is usually something to consider in an outpatient setting, in a mental health setting, where we otherwise might not think we would need to because it's cannabis.
This could be an emergency.
That's right, and we've especially at the CAMH, we've published on really thinking about medical supervision of withdrawal management in the setting of withdrawal from substances we normally wouldn't consider to be morbid or mortal, like opiates and cannabis.
Quick Takes is a collaboration between David Gratzer and CAMH Education. You can find links to the relevant content mentioned in this show, a video version of the episode, and accessible transcripts of all the episodes we produce online at porticonetwork.ca/podcasts. If you like what we're doing here, please subscribe. Until next time.